Hi friends, Angelica Vanetta, co-chair of Inclusive ICR. We are a coalition of over 220 employers in Eastern Iowa, all working together to grow the diversity and inclusion of our workforce, to create a space where employees feel a sense of belonging, included, and valued. Inclusive ICR is a proud sponsor of the Diversity, Equity, and Inclusion track of the Iowa Ideas Conference. As you participate today, be sure to connect with other Inclusive ICR champions, as we'd love to share information with you about our upcoming coalition meetings, projects, and how our work is impacting positive social change in our region. Be sure to visit our website at inclusiveiowa.org for information on upcoming events and to sign up for our e-newsletter. Thank you and have a great conference.
All right. Well, we are right at time to start this session, so we'll get going here as more people come in from our waiting room. I'm Vanessa Miller. I'm a reporter with the Gazette. I've been covering higher education and healthcare for several years now. And yeah, I would just appreciate everybody for coming and attending the Iowa Ideas Conference. I want to start by thanking our sponsor, ITC Midwest, and just letting everybody know that they can check out a video from our sponsors in the Whova app if you have any time to do that. This session is called Equitable Treatment and Services in Healthcare. So we have some great people here to help us out with that. I thought I'd start by just throwing it out to you guys to introduce yourselves and just ask you to share a little bit about your where you are in the healthcare space. Do you want to start, Diana?
Sure. Yeah, I'm Diana Jones. I'm the Chief Dental Officer at the Eastern Iowa Health Center. I have been here working with the company since we opened the dental building about 8 years ago, and we recently expanded to the building that we're in now, doubled our footprint, doubled our staff, and that was about a year ago. And it's an FQHC, so we kind of fill we're kind of the basket where we collect the people that need services that find it hard to get regular care outside of here. So we see a lot of Medicaid, we see a lot of uninsured patients, we see a lot of immigrant patients and undocumented patients.
Okay, yeah. And Carly?
Sure. Good afternoon. My name is Carly Ross. I am the Executive Director at Dental Connections. Dental Connections is a independent nonprofit organization that has, excuse me, sorry, got a cold, been around for over 100 years. We primarily serve our low-income children and adults who have Medicaid insurance. About 70% of our patient population has state insurance. We also serve, of course, uninsured and commercial insurance patients, high volume of refugees and immigrants. My background is actually working specifically with the refugee population for over 5 years. I was the field office director for Iowa's largest refugee resettlement agency. I also have experience working overseas in East Africa with the refugee population. So we have piloted several initiatives to improve access to oral health care for new refugees as they arrive in the U.S., helping to connect them to a dental home and make sure that they're getting some of those longstanding dental issues treated.
Awesome. Thanks.
So I am Maggie Martinez. I'm a social worker at Buena Vista Regional Medical Center in Storm Lake in Northwest Iowa. Our hospital is a critical access hospital. We see a large number of dental issues come through the emergency room because our residents cannot find a dental home here in Storm Lake. The diversity of our community, if you're not familiar, we do have Iowa Central College and Buena Vista University, but we speak about 25 languages in our elementary school. We have a lot of newcomers come because of the meatpacking plants here in town. Our newest group of immigrants, our largest and newest group, are Pacific Islanders from Pohnpei. So they bring with them many dental issues. And we have an FQHC here that has a large dental practice, but they are no longer able to take any new patients until probably sometime in the new year.
Yeah, great. Well, thank you. And I forgot to mention at the outset for people listening in that if you have questions throughout the session, feel free to send those to our moderator, and then those will come to me directly, and I can pose those to our panelists in real time so that we can keep the conversation flowing in that way and that you all can be involved if you have thoughts. So one thing I kind of wanted to start with is this session is called Equitable Treatment and Services in Healthcare, but all of you obviously have sort of like dental expertise specifically. So I guess I'm wondering if you could talk a little bit about how we ended up there from the idea of equitable treatment in healthcare, because I know obviously, yeah, a lot of patients have dental needs. So yeah, maybe just share a little bit about that and what the landscape is like there.
Did you want me to start again?
Sure. Yeah.
Okay. So I'm in Cedar Rapids, and we're really the only office taking Medicaid, and other than the University of Iowa. So I think Maggie had mentioned that the FQHC in her area isn't taking new patients. My understanding is that most of the FQHCs are not taking new patients on a regular basis because we're already pretty full. So we open ours for a week and we fill up really fast, and then we have to kind of put a hold, otherwise we won't be able to get our regular patients back in for their 6-month visits. So I think a lot of it's just an access to Medicaid providers, at least from what I see with the people I talk to.
Right. Yeah. Do you have thoughts, Carly and Maggie, on that? On, yeah, the landscape around that area?
Well, I think you can tackle that question from many directions. One major issue that we see are the Medicaid reimbursement rates in the state of Iowa are extremely low compared to other states. We typically say Medicaid reimburses around 30 to 40 cents on the dollar compared to a commercial insurance. And so it's very challenging for especially dental providers to keep the doors open if they are relying on Medicaid. It also makes dental providers reluctant to accept Medicaid insurance, and this becomes an issue, especially in more rural parts of the state. We have shortages, we call them dental deserts, geographic areas in the state of Iowa where patients with Medicaid have to travel an hour and a half or 2 hours just to find a dentist who will take their type of insurance. Here in Des Moines, Dental Connections, we have patients traveling from Fort Dodge on a regular basis to seek care. That's an hour and a half drive one way. So I think the low reimbursement rates is a major struggle. Speaking more specifically to the refugee population, they are very reliant on the services that they receive when they first arrive in the U.S. To be connected to healthcare services in general. And unfortunately, dental care is not a required service for their case managers under their federal contracts with the State Department. So if they're having dental pain, a dental emergency, it's really challenging for them to get connected to the care that they need. We also see that a lot of our refugee and immigrant patients have longstanding dental issues that have not been addressed over significant amounts of time. So the treatment needs are just very extensive. So just lots of access issues and gaps to fill with our population.
I would agree with both Diana and Carly. Here in Storm Lake, most of our newcomers did not have dental services, that just didn't exist where they came from. So the only treatment they knew of to treat a dental issue was to extract the tooth. That's the only option. You wait until it, I guess for lack of a better word, disintegrates. It's our children at our schools complain of dental pain daily. And if you have I've had toothache before. You cannot sit and learn in a classroom when you have a toothache. It's really quite difficult. Parents miss a lot of work. We have sent children as far as the University of Iowa, which is a 4.5-hour drive one way for a visit, to tell them that, yeah, you need, 14 teeth worked on, and then they drive back, and then we have to make another appointment. parents around here can't miss work at that level, you know, a whole day, 3 or 4 days to get treatment. So many of our children end up in operating rooms. We have a few pediatric dentists that will do that, but those are all at least 45 minutes away, and they're booked just like the FQHCs are. The reimbursement rate is probably our number one issue with getting our private dentists here in town to accept new Medicaid patients. Some of them have some older patients that they've kept, but are reluctant. That reimbursement rate has to change.
Right, right.
Yeah, I would like to tag team on that too. I think Carly is exactly right, and you're right, Maggie. Like the reimbursement rate is killing anybody from wanting to do it. I was talking to some dentists a while ago, and they were also concerned that Medicaid's just a lot more tricky to bill, and that there's a lot of rules around it, and they were worried that they'd get in trouble, and so sometimes they would rather just do the services for free rather than worrying about their license getting revoked or like getting in trouble or the money getting taken back or like the hassle of having to bill Medicaid. So there's also some misinformation, I think, that like if you take some, you have to take everyone. So there's just sort of there's like a lot of education both for Medicaid to increase their rates and then education to the dentist to like know that they're not going to get thrown under a bus for taking Medicaid. And then you both brought up the immigrant population, and that is an interesting challenge. In Lynn County, we have been required to see all of the dental patients, and I don't know if that was just my medical director's instinct to like, if you're going to come through, you're going to get both. So we've seen all of the Afghan patients that came through, and on the flip side of getting no dental care is when they've gotten some really quick, not sort of mediocre or not good dental care, and they're expecting quick stuff to happen, and now you're kind of trying to fix all the stuff that happened. And our system is different, and trying to cross that cultural barrier can be an interesting challenge as well. So both the patients that have never had it and don't understand why I have to come on regular care, and the people who have had lots of it and don't understand why they have to come for regular care, it becomes an interesting challenge, and again, educating the patient to understand why we require regular care.
Yeah, that's so interesting. And obviously, Iowa's foreign-born population really has been increasing quite a bit. Just, I mean, I think doubling it over several decades, you know, until today, and is expected to continue to grow. And so when they come to Iowa, is dental care often like more pressing for them than any other healthcare issues, or do you know?
I think only if it hurts. I think both of you
Yeah.
had mentioned that. Yeah.
Pain.
I guess I was wondering whether some of the countries that folks come from if they don't get regular dental care, whether that does seem to be something that they sort of need more urgently upon arriving.
I would say yes and no. It depends on the background. If we're talking specifically about refugees, you know, we have refugees who are coming from cities where they had more access to dental resources. But if you're talking refugee camps, you know, refugees can stay in camps for up to, I think the typical stay is 17 years. And so they might have access to medical services in the camp, but it's probably less likely that there would have been a dentist visiting camp to provide services. You also have the shifting diet of refugees, and you have the fact that they probably experienced malnutrition or lack of access to clean water while they were in refugee camps. Substandard living conditions in general can be really detrimental for oral health as well as general health. So it's very, you know, I think it's very specific to the individual, but the difference between the medical and dental once they arrive in the US is that the dental is not a required service for them to receive. And so I think that's where I kind of just see a little bit of a breakdown in the system, is that we know that oral health is essential to overall health and connected to so many other health conditions. So why wouldn't it be, you know, a given that they would get access to dental care alongside of the medical care that they need at that time?
Yeah, absolutely. Well, and I guess I'm wondering, and I don't know exactly how long each of you all have been in your specific positions or spaces, but have you seen this issue getting worse or becoming more pressing? And if so, can you talk a little bit about that?
Here in Storm Lake, yes, it has increased dramatically over time. Our FQHC has added a dentist, and he was, like Diana spoke of, he was full before he got credentialed probably. So that has been an issue. Some of our dentists have accepted these, very small pockets of Medicaid because they realize we're in a bind. We have a couple of the transportation is a huge issue. We have a taxi service here in town that runs Monday through Friday, never late in the evening when some of our people could get to a dentist. Traveling out of town is expensive. If they have Medicaid, that can help. And then the difference, and I won't mention which one, seems to be accepted more than the other, but with Medicaid, there are two providers here in Iowa, at least there is in Northwest Iowa. And some dentists will take one of them, but they won't take the other. So
I'd
then
love to say which one is the one that they won't take.
I don't need to say that. It's all the same, I'm
They
sure.
make it very difficult.
Yeah, they make it very difficult. And, we are, hopefully growing our own dentists. We have two local kids, I call them kids, have now gone to dental school and hoping they will come back and maybe there can be some grant systems or something to help them.
One of the insurance companies gives out grant money also, and the other one does not.
Right.
So
Right. So that is one of the things. The other thing that we notice with our immigrants, and our public health department is just wrote a couple of grants, is the use of bottled water almost exclusively that is not fluoridated. So that we're trying to focus on that a little bit to show them in Northwest Iowa we have very good drinking water and to use it. But the money that is spent, and it's not good for our planet. There's a lot of aspects of bottled water that we need to get away from. So our public health department social worker wrote a grant, and we're putting some bottled, some new fountains around the city, trying to encourage the children, teaching them about drinking our water. It's not going to solve the children that have 12 teeth that have to be extracted. That's not going to solve that problem, but slowly but surely, it might make a difference for some of our kids.
Yeah, absolutely. And so, I mean, yeah, obviously, so we've got, the Medicare, the financial piece, we have the travel, like it's difficult to get to a location. What are some other barriers we're talking about? I mean, obviously, like, is language sometimes an issue, or I don't know, how hard is it for them to navigate that piece of it?
We often physically take them. We have a couple of social workers in town that try to help them get to these appointments to help them understand that, yes, you're going to go to this first visit. And I think Diana spoke of it a little bit. That's not going to solve your problem. That's the first visit. And then you're going to be rescheduled and you'll have to come back for multiple appointments. So that maybe that is one of the reasons these children are going to operating rooms, which is very invasive to have to go to a hospital and have general anesthetic to have your teeth fixed.
Yeah, particularly if you aren't, super clear on what's going on.
Right. Language is an issue.
we
Right.
use AMN as the company we use with the iPad, so we can kind of link into various languages that way. Today I struggled with mine, and we were lucky there's a man who speaks Swahili, and the family also did understand Swahili. So we have a couple people who speak various languages around, but mostly we use the iPad. And then Delta Dental does also have a language line that people can call into to help with translation services, and that's free for people who take Delta Dental.
Yeah. Awesome. Oh, well, and obviously we're talking a lot about the immigrant population and about the gaps and resources there. But are there other equity issues for other populations of people in trying to get care, including like people with special needs or, just low income in general?
Yeah, I'm going to back up just a little bit, and then I'll answer that more directly. In general, I would say since about the end of 2020, and I don't think it's related COVID really, but we've seen the number of emergency dental care needs increase. So we started doing just a walk-in system because we were taking too many phone calls and spending too much time scheduling emergency patients that are not regular patients here. So we now just do a walk-in service, and kind of any patients that don't show up, we can slide the walk-in patients in, and they know they have to wait. And I mean, we can get up to I think we've had 17 in an afternoon before. So it can be, it's a little bit shocking to me how many patients are, waiting until it's really hurting, and then getting services. That being said, nobody's taking Medicaid. So they're, they come in and they say, okay, now you fixed my tooth. Can I come back for a cleaning? And the answer is no, because I don't have any openings. To answer your question about special needs, and then I'll let somebody else talk. We also recently started trying to help out there's a pediatric office, dental office associated with one of the hospitals in town, and they are trying to kind of revamp their program and focus more on the children. So they're asking other people to take the special needs population. So we've started to see that group, and I've come to realize that there is nowhere for special needs adults to go. And the University of Iowa is booked out. The hospital has a hospital dentistry program there, and they are booked out 2 or more years for patients to go in to become a patient, just to become a patient there, knowing that those patients will all need OR services. And Maggie, in addition to it being invasive, they're also often booked out 6+ months just to get into the OR. So when you have somebody in pain, it becomes really tricky to try to get them to cut a line of people that have been waiting years and years to get in for regular care. So now you have this special needs population, many of whom are maybe not verbal, and the family, and unfortunately, this is like just in general, dental care is not considered as important as healthcare in this country, and so people think like it's going to be fine. They don't have any problems. I don't see any problems, but without X-rays, you really don't know. So you're waiting until it becomes a problem, which means now the tooth has a huge hole and it's incredibly painful, and now you're waiting to get into an OR. So it's a pretty complicated problem that I've fallen into.
Right. Yeah, absolutely. I mean, is part of the reason, obviously, we've talked a little bit about the Medicaid piece of it and how having dentists that, will accept Medicaid patients is a problem. Are we lacking in just dentists, like in general? Like, do we need more providers in Iowa?
I don't think so. I don't know about you guys, but there's a ton in Cedar Rapids.
Yeah, okay.
We're a bit of a desert. I mean, we have several private practices that are very popular and are great dentists. We have a great relationship with them, and we can usually get people in. It is easier, obviously, to get people with private health insurance. I could likely call my dentist right now and get in today if I would, which is not equitable. That's exactly the opposite of equitable. The other aspect that I have seen most recently with our children is our parents are making a little bit more money, and now they're falling out of the Medicaid realm and they're going to Hawkeye, which is a good program, but the dental piece is limited. And I'm not sure if it's $1,000 or $1,500, but
1,000.
1,000. Well, it's been that since my kids were little, and they're 40 years old now, and they were not on Hawkeye, but private insurance. I mean, the cost of dental care has gone up.
Mm-hmm.
Right. Absolutely. I mean, yeah, it's really interesting because I was thinking about the training piece of it at the University of Iowa, and looking at its dentistry program, and that they have the highest tuition rate, like the dental students. I mean, it's super high. And when they say that they're doing differential tuition, I mean, the dentistry students are paying probably the most. So in terms of training, I don't know where that comes into play and if we need more to stay around or not. But I guess, yeah, just like talking about the sort of Iowa ideas piece of this puzzle, like what are some things, some additional resources or some changes that you all think need to be made to help address this issue?
Well, I'll this is a dream. It is a dream, and I'm not a member. I don't work for an FQHC. I work for a critical access hospital. I see dental schools going on mission trips frequently, and I think we are a mission. I want them to be able to go to the mission trips because a lot of these students have never traveled outside of the country. I would like to make that mission, a week-long stay. We could get through an enormous number of children. And I'm just talking children. When the adults, that's a whole other game. But if we could get through a lot of children in a week's time with dental students, their attendings, and even using an operating room if that was necessary, those things we could do. And that is a dream of mine. I am working with some other dental schools that are a little closer than the University of Iowa because, like Diana said, they're booked. It's very difficult to get into those programs. We go to legislative breakfasts or coffees 3 or 4 times during the legislative session. It's brought up every single time. Dental reimbursement. Every time.
Right. And what's the response?
We know.
Okay.
We know. They know.
But no commitments there.
Yeah. It's hard. It's difficult. It's very difficult to convince people that this is it's education, it's the workforce. If we can keep people in, it's difficult to get a workforce. People are all struggling that way. If we could keep them at work so their children don't have to travel 4.5 hours one way to see a dentist, that's good for business. It's good for the children. It's good for the schools.
If you can keep people out of the ER,
out of the emergency room,
Medicaid, yeah,
absolutely. It saves money. It saves a lot of money.
So sort of off topic, I suppose, but when I was in dental school, so maybe 10-ish years ago, the Medicaid expanded in Iowa, and the Delta Wellness Plan expanded for adults, and they were reimbursing closer to 70%. And I think after those adults had been in the program for 6 months to a year, some of the benefits started to kick in, and I think Medicaid realized how expensive it was and kind of panicked and pulled it way back. And so then it all went down to that 30-some% reimbursement rate. And now there's $1,000 cap on adult Medicaid also. And so it's I think it's out of sight, out of mind for the people who are making the rules and the people that suffer are those that don't know that they have a say in it.
Right. And are they just being turned away, or how is it actually playing out for folks that are trying to come in and get care? Is it a charity care situation, but then they just don't get any follow-up, and so it continues to be emergent? Or what does it actually look like for the patients?
I think they don't go anywhere until it hurts and then they go to the ER. So I think we've been here long enough. Patients know that they can come here, and with our emergency walk-ins, we've made sure that both hospitals know that they should be redirecting tooth pain here. So I think people find out that nobody takes their insurance. Dental care is expensive. You can't just walk in and honestly, most people don't have $100 they can spend to pull a tooth, and it's more expensive than $100 to pull a tooth. So people aren't able to walk in and get dental care, and dentists aren't going to let you get dental care without paying. So it's so you just don't go.
Right. Or you end up in the emergency room, as you said.
Yeah.
But your plan of using walk-ins for emergencies to fill in those slots that are no-shows, because no-shows are very expensive for dentists. That's a brilliant idea that should be, and I don't know how many dentists you have, but that really is a way, and people understand if they don't have an appointment and they're in pain, most people are willing to wait.
We had 3 before. We have 6 now, and it's a lot easier to do same-day treatment, but it was also difficult when they'd come in and I'd plan it and say, we'll call you tomorrow when we have an opening, but right now just have to wait. But now we're able to I think we're able to see to pull whatever teeth need pulling or fix it or make a referral for it depends on what people need. So we're usually able to complete the project when they come in.
Yeah, we do the same thing. We offer emergency patients to come in on a walk-in basis where we don't guarantee treatment the same day, but more than often we can see them within an hour or two. We end up seeing over 125 patients each month on a limited basis. Some patients have insurance, some pay out of pocket. It really depends. We're fortunate now that we are able to take new adult patients for comprehensive care. So even if they come for an emergency, we can often get them back for that cleaning and established care, which is really exciting. But in other parts of the state, like everyone's been saying, it's just really challenging to find comprehensive care if you don't have insurance or if you have Medicaid insurance. I think
Right.
the numbers are 30 years ago, about 62% of dentists accepted Medicaid, and right now that number is about 14%. So it's a very low number, but other states have been successful in increasing Medicaid rates. Missouri recently increased their rates to 80% of usual and customary rates, which is excellent. Minnesota and Texas have also recently increased their rates. So we're really hopeful that here in the state of Iowa in the next year or two, our legislator will agree to increase Medicaid rates for dental, especially.
Yeah, so those percentages that you provided for Iowa, that it was like 64 down to 14%.
62 down to 14. Yep.
62. Yeah. Yeah. And maybe this is a question for Maggie, but what about other areas of healthcare are we seeing disparities in? I mean, is it most pronounced when it comes to dental care, or are there other needs that really aren't being met for various populations?
Well, we are a rural, we're kind of an urban rural area. We have a population of a guesstimate because we didn't have a great response to census in 2020 for obvious reasons, of about 15,000 people. We are short on medical providers, desperately short of medical providers. We have 2 Unity Point clinics and then our FQHC. Our FQHC does not have a full-time physician right now. They do have, I believe, 4 ARNPs that are very busy. We can usually get people in, but again, emergency rooms are frequently used for primary care. And also because we do medical and dental care very different than any of the countries that our people come from. They go to a clinic that looks like an emergency room where they come from. And so that's what they're used to. So education is important. Our school nurses do a phenomenal job of educating parents on how to access the healthcare here in Iowa, and they should be commended. They're kind of like miniature clinics in themselves. So they do a lot of connecting people to their resources, and our public health department as well.
Yeah, yeah, great. Well, and so obviously, we've been talking and focusing, on the implications of this for the patients who can't get care. And you have talked, some about the clinics and the dentists. But how are providers doing right now in terms of balancing, the big demands that kind of did come out of COVID and some of that backlog? I mean, are they doing okay financially? Is that part of the reason they can't accept Medicaid, or are there still struggles?
My impression is that it hasn't had a huge effect on them, and I think they all bounce back pretty quickly. I know anecdotally, but for a fact that people were not taking Medicaid well before COVID. So, I mean, we were one of there was maybe 2 other offices in Cedar Rapids that were taking it, and Cedar Rapids is a big enough town. I mean, there are you can't like you trip over the dental offices in this town. So it's it was as soon as Medicaid changed their reimbursement rate from that the wellness plan went from 70% down to 30 whatever, then everybody stopped taking it. It was pretty immediately after that. And like one of you guys had said, some rollover patients, but then maybe there's a new dentist comes in and they're like, nope, like I'm not grandfathering in, not my patients. So those patients would get kicked out. And yeah. And then when that second MCO or whatever you want to call it came on board, nobody wanted to take that. So then that dropped patients in half also, because then the insurance that was doling out their Medicaid wasn't accepted by their providers.
Right, yeah. And remind me when that drop happened, the
It
Medicaid
would have been
reimbursement.
like 20, uh 17, maybe 2017,
Oh,
20.
okay. Yeah. Do
Yeah.
we have, because obviously things vary by state, are we losing people because of issues like this? Are people leaving the state? Do you get a sense, so that they can get better access to things out elsewhere?
For dental care?
Yeah, sure. Or yeah, or healthcare in general, or do you know?
I wouldn't think so, because if you're on Medicaid, it covers it. So you just have to get, like, you wait until you have pain and then you go somewhere where you can get pain treatment. I think most FQHCs will take you for pain. That's kind of the standard for the FQHC. And the University of Iowa, it is there. You just have to suffer through. And honestly, tooth pain lasts for 2 weeks and then it goes away. Or you go to the ER and you get some antibiotic and it maybe helps for a bit. And so then you wait, so people kick that can down the road until they can't anymore. Um, but I don't, if you don't have money, you're not leaving the state for services you can't afford in the state.
Right. Okay. Yeah, that makes sense.
Now, are our dental students leaving the state? That would be an interesting look. We do have, I don't know how large our dental school is, but if we're going to educate people here in the state of Iowa at a state school, I think we should do something to try to encourage them to stay here in the state. And
Yeah, it's a good question. Maggie, there's 80 students per class. But most of them are not Iowa based, I don't think. There's not a lot of dental schools in the country. But I don't know that it's a dentist supply problem though. It, but there are not a lot of I don't think every state has a dental school. So you get a lot of out of state, students.
Yeah. Yeah, I mean, is the equity issue and the access issue worse in rural parts of Iowa versus urban? Can you talk a little bit about that?
well, we don't trip over dental offices here in Northwest Iowa. And certainly as far as pediatric care, we do not have a pediatric, specialist here in Storm Lake. We have one about 45 minutes north in Spencer. Otherwise, Denison, which is an hour and 15 away, or Sioux City. So, that's quite a bit of travel. And if they have extensive dental issues, which those are the ones that are coming to the emergency room with 4 or more teeth that often have to be pulled. Those kids were trying to get into these larger places like Denison, Des Moines. We get to Des Moines, Iowa City. Now, obviously, it's going to be Cedar Rapids because now I know about this FQHC. And
For what it's worth of those looking, the Iowa Primary Care Association website has a list of all the FQHCs that are out there, and I am under the impression that most of them are not taking new patients, but should be able to handle some emergencies too. So because there's a couple up by you. It's just
we use Fort Dodge, we use Sioux City frequently. They've been pretty helpful. Ours is just relatively small.
Yep.
There's only 2 dentists, and they can only do what they can do. So language doesn't seem to be a barrier there.
Just want to mention there's also a few programs that offer, for example, student loan forgiveness if you find employment in a geographic area of low provider density for the public health population. There's the public health forgiveness loan is one. There's another where you have to work for a nonprofit for 10 years, I think, to have your loans forgiven. So there are opportunities for new providers to have student loans forgiven if they are working in the public health space, which I think is really exciting.
Yeah, yeah. I mean, obviously, like the University of Iowa has done different rural specific programs to try to retain healthcare providers across the state once they graduate. So I think that there are some programs like that, nursing, uh, and PA sort of specific programs. So talking about solutions, obviously we've talked about some of the systemic potential solutions there, or provider solutions. Is there anything that you think the patients themselves, like when we're talking about, a lot of times people say like, oh, if we could just educate people on this or that, I'm saying that would be helpful. Like, what can they do differently or at all to help themselves or advocate for themselves in this arena?
We say drink tap water. That's a big thing here. We're really
Yeah.
pushing it right now. It is not going to solve the 200 children that have extensive dental needs here in Storm Lake and the
That's
surrounding
really
towns.
that's really funny, Maggie. I say don't drink soda. So
There you go. Yeah, and that is an issue. We have, if anyone wants to do a little bit of Google rabbit hole, if you look at our Pacific Islanders and what the United States, what we did as a country to the Micronesian islands, during World War II, and what has, the food that we dropped to them because we decimated their islands. They were not teeth friendly
mm-mm.
foods, and this has had a catastrophic um, result in their dental care. So
Yeah.
That's a much more educated Google search. I usually just tell people to search Mountain Dew mouth, and then that sort of answers.
Mountain Dew mouth.
oh no, I don't. I'm gonna write that one down, but
Yeah.
yes, very hard.
Yeah.
Yeah, and Maggie, when you were talking earlier about kind of a service project or mission, were you envisioning that like in your pie in the sky vision for to happen here, like in Iowa, like that there's like
Yes,
a sort of like a clinic that is set up to just do like basic.
I'm going to go to dental schools. Well, we're very close to Nebraska. There's a couple in Nebraska, and we'd like um, to offer that. I don't know what it looks like. I don't know, if there's 80 students, we certainly can't have 80 students coming into a clinic. I haven't spoken to the FQHC, but we have to figure out a way to get on top of these extensive issues. We have children that are having 10 or more teeth removed, and these children are in elementary school. This is not
Right.
uncommon.
Yeah, and what, go ahead.
I don't know I'm not a dentist. I'm a social worker, but I don't think that's good for your overall health to have
Thank you.
that kind of work
I
done.
just want to talk about a program that we have offered in the Des Moines area for over 20 years. It's called our Smile Squad Mobile Dental Program. And so we have 3 mobile dental units. These are full service mobile units. We offer comprehensive care, x-rays, exams, treatment right there on the mobile unit. And we go to over 60 schools across 8 school districts in the Des Moines Metro. We pull kids right out of the classroom. We have a signed permission slip from parents, and it allows us to provide comprehensive care to children regardless of their insurance type. It's really beneficial because parents don't have to take time off work from school. Kids are only pulled out of the classroom for maybe an hour at most. And we can actually complete treatment right there from the parking lot. So we're looking to expand this program, but we are serving, hundreds of students every year. A lot of those students are undocumented. They don't have insurance, and we're able to donate that care through our charitable care policies. So I think this model has worked well in other states. I know South Dakota also has an expansive mobile dentistry program through Delta Dental. But I think some of these more innovative models for actually providing care right there on site are really helpful because transportation is such a major barrier for some of these populations. We also have had a refugee care coordination project in the past where we had a dedicated care coordinator who really facilitated contact between all of the different partners, made sure that they got to their appointments, that they were scheduled for the follow-up visits, make sure there was an interpreter present. Sometimes in order to achieve equitable access to healthcare, you really have to take a few extra steps because not everyone has the same level of understanding and level of need. So we found that to be a very successful model. We were able to treat hundreds of refugees and establish dental homes for them, not only at our clinic, but at our county hospital and at a local FQHC. So I think collaborating with key partners in this space is really important. No one single clinic is going to be able to tackle this problem on its own. We really have to work together and build a system with, a network of providers who are willing to serve this population. I don't really think there's anything that we can speak to as far as what patients should be doing differently because we have a broken system and it's our responsibility now to fix it so that it works better for the patients who need us. So these are just a few examples of ways that I think that we can think outside of the box so that we can better meet the needs of these patients.
Yeah.
I like that a lot, Carly. The dental school, they send so I've been having dental students train under me. But when I was in dental school, we would go up to Postville and work out of the school there for one day, every 5 weeks. We would, they go into a nursing home with a mobile unit. So those dental schools have some of that capability. And then they also have the desire to give those students that training. I think there might even be some requirements, for credentialing for them to have those experiences too. So I don't think it's hurtful at all to reach out to the administration at the various dental schools and ask them if they're interested in coming or partnering or brainstorming or something like that, because I think they all know that there's a crisis.
Yeah, I think that collaboration piece, I'm just seeing it across all industries, as there's things are becoming more unsettled in various ways. It's like, working together and collaborating seems to be a lot of the problem solving there. I was going to ask whether there are other states or other sort of like models, in other places that you all have seen that you would like to see implemented here or that we could learn from in that way?
I'm thinking just in the state of Iowa, the inequity. In Des Moines, they have the access to mobile dental units, and in Cedar Rapids, they have dental clinics where you can sit and wait, maybe all day, but you're going to see somebody. Those opportunities do not exist throughout the state, and I think that's very important that we kind of spread the love. And it is great that the dental students, do I think Iowa City should send dental students 4.5 hours away once a week? That's not realistic and that's not going to work. But we are 2.5 hours away from 2 other dental schools. So that's something that we could do. And I think traveling around the state to see the other programs, I've been to Des Moines and I've seen some of the incredible dental work that's been done down there. And I would like to model that up here. It has gotten considerably worse in the last 4 or 5 years, and I don't think it really necessarily had anything to do with COVID. Like Diana said, I think this was coming all along. We just have had a lot of newcomers to our community that have brought with them more issues, and on the other hand, the untreated dental issues are going to cause life medical issues. So we're going to have to address it, and Medicaid may be part of that. And it's going to cost a lot more money to fix this after not treating them in the manner that they should have been treated. Like I can get treatment for myself.
Yeah, it's hard to know how much of it's the immigrant population because they kind of happen simultaneously, I think. But the Medicaid rate, I mean, like Carly hit it like right out of the bat here with when we started this conversation that I think the need started to skyrocket when the providers stopped existing. And even though there are 1 million dentists in this town, nobody's taking Medicaid. So, whenever somebody's mad at me for whatever policy I've implemented, this is what I have to work with. So, it's tricky to compare state to state because each state really does have different Medicaid. There are some states with no Medicaid reimbursement for dental. So, as bad as it is here for access, the FQHCs that are working without any Medicaid dollars coming in, and they're just getting whatever government grants they can to offset the low income patients sliding fee scales. I don't really know what the answer is, but it's just something. There are organizations out there that are working towards making it better, but it's going to take a team, and I think it was Carly also said we all have to work together, and the system's broken.
I do think we can look to other states for examples of where we should be going. For example, Missouri increased the rates in 2022,
Yes.
and after doing so, they brought almost 200 more dental providers onto their Medicaid network, which allowed them to serve more than 50,000 new Medicaid patients. So that right there shows you that if you do increase rates, more dentists are going to take that insurance type and more patients are going to get access to care. It's very simple. And there are other states that have the same, proof. So I just think that is such a, I don't want to say easy solution, but obvious solution.
It's very obvious.
And that's really where we're focusing our energy right now.
Yeah.
Yeah. And I mean, all of you kind of hinted at this, but I'm just wondering if you could talk at all about where we'll be if nothing changes. Like where will this go, and what could be the implications? I mean, I know Maggie, you'd mentioned trickle down effect into other health issues, across a pretty tight healthcare system already too. Yeah, what do you think about that?
I'm not a clinical person. I'm a social worker, but you see kids again and again. First of all, you're keeping them out of school. We have a new statewide attendance policy for education, and which is important. We need, rears in the seats. We need our children to be in school. That helps our entire society. We need people to be able to find jobs if they're missing all of their teeth at even as a child or as an adult, that's going to affect their ability to find work. These are things that are, it's a quick fix. Carly said it. It is a quick fix to change the reimbursement rate. Number one, very quick fix.
Yeah, because there's a mission of mercy that happens every year, I think in every state, and people line up around the block starting at 4 a.m. in relatively often chilly weather, and it can kind of show the need that's happening. I think it ends up just becoming kind of a drain on the system where people are going to the ER, or they're waiting until it's a problem. But I think healthcare in this country is just sort of a fraught topic, and dental is often not considered healthcare, and so it's often sort of the ugly stepchild of a topic we don't discuss, right? So until we kind of get some agreement that healthcare is important in this country, that equitable healthcare is important, that I think we got to come together on that first.
Yeah, absolutely. I mean, right. Yeah. And I think it crosses all spectrums, not just dental care, but in other healthcare too, across the country, across the state. Well, we're getting close to the end of our time. Do you all have any parting thoughts? We didn't get any questions from the audience, so just mine and yours. But yeah, anything you want to leave folks with on this topic as we kind of move forward?
Legislative session will be opening in winter. Access your legislators, talk to them often. If it doesn't affect you personally, it still affects the community that you live in. No matter which community you live in, know your legislators, talk to them. They all have legislative coffees 3 or 4 times during the session. Go to the Capitol, spend a day there, talk to people and tell them how important it is. Reimbursement rate could change the way our children and adults are being treated as far as dental care is concerned, for sure.
Yeah, and we're talking about a lot of Iowans, about 700,000 Iowans have Medicaid. That's almost a quarter of our state's population, and a lot of those are children. And we want to give them the best start, and that starts with having a healthy mouth. So I think this is a really important topic. I think we need to keep putting oral health at the forefront of conversations about overall health. And like Maggie was saying initially, being able to smile with confidence and not experience pain when you're chewing, when you're talking, having a healthy smile is a really important start for a child socially and academically. So if we're investing in our children, we're investing in our population, making sure that they can access appropriate oral health services is very critical.
Yeah.
Yeah, I think you guys summed it up. It's hard to watch people really be embarrassed by their teeth, be in pain. Before we expanded, and I really couldn't cheat my rule about no new patients and sneak somebody in for a full care for cleaning. Sometimes everything hurts just because you need a cleaning so bad, and so you're there telling a patient, like, I'm sorry, I can't help you, when you know you can, but you also can't. Yeah, it's been really good opening this new building and expanding. And sort of ironically, yesterday I met with my CEO to talk about expanding again, and he goes, "We didn't open a year ago, Diana." What are you guys talking about? And I said, "Well, we already have a wait list of 200 people that would like to have comp care, and it took us 1 week to fill 2 months of new patients." And so I like, if we can staff it and we're profitable, then why not? So
Yeah, absolutely. Well, thank you guys so much for your work on this topic and for participating today and sharing your thoughts. We really appreciate it. Yeah, I want to remind everybody who is listening in that there are more sessions tomorrow as well. So today and tomorrow. So yeah, you can check out the agenda there. And thank you guys so much again. I really appreciate it.
Thank you, Vanessa.
Okay.
Thanks for having us.
Yeah. Bye.
Bye-bye.
Bye.
Bye.